Okay, let's get started because I know it's pretty late in Italy. But welcome everybody tonight to the Miami Global Brain Tumor Symposium. Again, special thanks to our great symposium and everybody who we've had on the last year. 2021 was fantastic and looking to continue in 2022. My name is Mike Ivan. I'm one of the neurosurgeons here at the University of Miami, and I'm joined by my co-faculty, Dr. Komatar, Dr. Morkos, and Dr. Benjamin, who are all brain tumor and skull-based experts. Each month, we put on these symposiums with the support from the Sylvester Cancer Center, the University of Miami, and the Department of Neurosurgery, and all their administrators, and we couldn't do it without them. We send out emails to over 5,000 people every month to kind of update them on our ongoings. We update on social media and YouTube, and these are the people that help with that. If you want to learn more about the department or the symposiums, you can always find us on social media or the web. In addition, I encourage everybody to visit our YouTube site at the University of Miami Neurosurgery, where all of the brain tumor symposiums, the skull-based and vascular symposiums, and the pediatric symposiums have been logged and categorized for you to view at future time. Again, please, we want to make this as interactive as possible. We want to answer all your questions, so please use the Q&A button throughout tonight. Also, we don't offer CME. And please be sure to like, follow, and share our videos on social media so we can continue to spread the word of our outstanding speakers. And just to remind you, again, this is monthly. We will find each other every Wednesday afternoon or evening on the first Wednesday of the month. So please join us next month. So moving on to tonight, we again have the University of Miami team panelists joining us, Dr. Higgins, Dr. Patel, Dr. Cater, and Dr. Morell, who are all part of our fellowship program for brain tumors. And have all done a fantastic job throughout the past year helping us out with these talks and also providing some good insight in cases. But let's get to tonight's speaker because he's joining us all the way from Milan. And I know it's a late night over there. And so we extra special thanks for him for staying up late and bringing some coffee to join us is Dr. Francisco Prada. Dr. Prada is a surgeon in the Department of Neurosurgery in Milan at the Institute Neurologico Carlo Besto, and he conducts clinical practice mainly focusing on skull-based, pituitary, and neuro-oncology. He also has a large research program where he's studying intraoperative applications of ultrasound for the treatment of cerebral and spinal tumor, as well as vascular lesions, and advanced ultrasound techniques such as fusion imaging for virtual navigation, contrast-enhanced ultrasound, and elastosonography. He's also an advisor to the Focused Ultrasound Foundation, and he's been a part of their program for several years and holds adjunct faculty position at the Department of Neurosurgery at the University of Virginia, where he's worked closely with Dr. Ilias on Focused Ultrasound. He's also a recipient of the Focused Ultrasound Foundation's Richard Merkin Fellowship, which is a very established award. He has more than 125 papers and manuscripts, most of which are on brain tumors and novel innovations, such as he's going to talk about tonight. And we just thank him so much for helping us kind of discover and talk about focused ultrasound and what is the latest and greatest on this technology. So Francisco, thank you so much again. I really appreciate your time tonight.
Well, thank you, Mike, for the invitation. Good evening, good afternoon, and good evening, everybody. Okay, now, as I was saying, thank you again for the kind introduction and for the invitation. It's a great opportunity for me to be here and talk about sonodynamic therapy, which is one of the modality offered by focused ultrasound to try to treat brain tumors. This is an interest I developed during my fellowship, as you mentioned, at the Focused Ultrasound Foundation in Charlottesville, and I had the opportunity to work to do some preclinical research on sonodynamic therapy at the University of Virginia. Now I'm conducting my research and continuing my research in my lab at the Carlo Besta Institute in Milan. These are my disclosures. So in this presentation, I will keep it simple and tight because it's quite late night here in Milan. So I will provide some overview of the basic principle of ultrasound and focused ultrasound and how we can deliver the ultrasound to the brain. And then we will talk and discuss about the concept, the mechanism of action, and what are the parameters and sensitizers used for sonodynamic therapy. And then we'll move to some example of a preclinical and clinical application of sonodynamic therapy, and we will discuss in the end how to eventually move forward. So please feel free to interrupt me, and yes, please, let's keep this as interactive as possible. So as you know, or as you all know, ultrasound are a form of mechanical energy. It's a mechanical wave. The difference with normal sound that we can hear is the frequency. They were discovered during World War I by Paul Langevin, who invented the sonar to detect submarines. But then after that, there has been a wide application of ultrasound for medical application, mainly for imaging, but since the 50s also for therapeutic purposes. And actually, the difference when we want to, with a common ultrasound imaging scan, is the dose of ultrasound that we use in order to obtain a therapeutic effect. So either we increase the power, either we increase the energy that we deliver, or we can also increase the duration of the ultrasound. We can obtain biological effects. So these are a few examples. So when we use transmit and receive probe with the low power, we can generate ultrasound images such as B mode, and we have different modalities. Nowadays, ultrasound is really multi-parametric, like the MRI. So we can have B mode, contrast enhancement, Doppler, elastography you mentioned before. Then if we have a higher power or exposure, we can open the brain vessels. We can perform sonodynamic therapy, for example, or we can even perform neuromodulation. And with a higher intensity, we can generate heat deep in tissues, so we can create thermal ablations or use the mechanical power to literally destroy tissues without thermal rise. Focus ultrasound specifically is different from usually from imaging. It's the concept is similar to that of radiosurgery, where we have multiple ultrasound beams intersecting at a focal point. The focal point is usually really, really tight. The difference with the radiation therapies is that the single beam doesn't produce any harm, but there is a profound effect at the convergence point. The problem when we think about delivering the ultrasound to the brain is that, as you know, we have to trespass the skull. As a matter of fact, transcranial ultrasound imaging is not possible except from some temporal windows or the ocular window. This is because it's like a wall for the music. So basically, the skull absorbs 90% of the ultrasound energy and then deflects and create a scattering of the ultrasound. So we need to get over it. And there are different modalities that have been applied. Apart from the imaging, where we either use the transcranial windows, or during surgery, we actually cut a window through the skull, and then we have direct access to the brain. If we want to be, let's say, non-invasive for treatment and deliver ultrasound energy for different purposes, we have to solve the skull problem. There are three main modalities. The first one is through MR-guided focus ultrasound system. Then we have a navigated system, and lastly, we have, for those patients who require surgery, implantable devices that can be installed at the time of surgery. So this is an example of an MR-guided system. This is the most widely used device. It's from Insightec, and basically we have sort of a helmet with more than 1,000 ultrasound elements that deliver the ultrasound across the skull. The head of the patient is fixed within the bore of the helmet with a stereotactic frame, so it's very, very accurate. It's a great tool for thermal ablation because it's MR guided. We have a quasi real-time MR feedback, MR thermometry feedback, and also we can, there is a cavitation mapping system. Cavitation is the oscillation of microbubbles, of gas bubbles when exposed to the ultrasound, which can be also uncontrolled if we deliver too much energy. So it's important to have such a feedback. It's quite time consuming. It's an expensive device, but it can be very, very precise and accurate. Then we have a navigated ultrasound system. Basically, we have a huge ultrasound transducer with a fixed focus. And actually the transducer is navigated sort of like the navigation pointer, and they're very accurate. We can plan the treatment relying on a preoperative MR. The monitoring of the acoustic feedback is less precise than with the MR guided system. And the phase correction, which means the correction of the beam across the skull, with the system only cannot be achieved. So it's a little bit less accurate than the MR guided. But in order to correct this scattering generated by the skull, there are some research groups, such as, this is an example, this is a group led by Jean-François Aubry, who was a former fellow of the Focus Ultrasound Foundation before I joined them. In his lab in Paris, they developed some acoustic lenses which basically mirror the skull in the area where we are going to deliver the ultrasound, in order to deflect the ultrasound that will be focused by the skull, actually. So this is a very smart option. And then we have implantable device. This is the first, the SonoCloud system. It's been developed in Paris as well, where we basically have an ultrasound transducer that is implanted through a burr hole at the end of the surgery. Now they are developing a 3x3 grid, so it's a bigger system. And this can be activated through a needle that provides the energy. And they already are in a clinical phase, and they showed, when coupling the ultrasound with the microbubble administration, they can open the BBB, and they showed that there is a higher delivery of drugs across the BBB, with an improvement in the overall survival. One of the only issues that requires a surgical procedure, of course, and there is no feedback, and it's a sort of a blind shooting. The ultrasound beam cannot be directed. It is fixed. Our group is relying on our experience on intraoperative imaging with ultrasound. So we like the ultrasound so much that we sought to use the ultrasound also in the follow-up, or even to perform ultrasound guided therapy. So we are developing a prosthesis that will replace the bone flap that we remove at the time of surgery, and that remains there, so that we can perform exactly ultrasound imaging and therapies in the following months in patients, for example, in tumor patients. So while at UVA, we performed the acoustic characterization of the prosthesis. We found that there is no distortion. The absorption, the attenuation is much less than that provided by the bone, is 10% instead of 90%. And in a preclinical model, this is a scanning pig across the prosthesis, we found that it's quite feasible to evaluate the brain. This is an example without the prosthesis, and this is with the prosthesis. So there is a little bit of distortion, but not much. And we did already a first implant in a patient, and in the video you can see 6 months after surgery, we can have a B mode scan. You can see the prosthesis here. We can scan the recurrence of the tumor. We can also perform microbubble imaging, which means that eventually we will be able to perform ultrasound guided BBB opening. which we did actually in this ex vivo perfused guinea pig brain. So this is a brain that is perfused with microbubble and it sits in a water bath. Here we're opening in this area, in the shaded area, the blood-brain barrier using therapeutic ultrasound while looking at it with a diagnostic probe. And actually we managed to open the blood-brain barrier across the prosthesis. And being the parameters for BBB opening and sonodynamic therapy pretty similar, I think we think that even sonodynamic therapy will, it will be possible to conduct sonodynamic therapy across the prosthesis in the future. So we are looking to develop this ultrasound guided modality. So going back to the topic of the talk, which is sonodynamic therapy. In this panel, you can see that are summarized most of the neurological and neurosurgical conditions that can be treated with the therapeutic ultrasound. So when we talk about, as mentioned before, high intensity focus ultrasound thermal ablation, we can have really tissue ablation, and this is used as an established, it's FDA approved for essential tremor, and I think Parkinson's disease. And there are many studies undergoing for psychiatric disorder, pain, epilepsy, other conditions. Then with medium intensity ultrasound, we sought to perform BBB opening. And with low intensity, we move towards either sonodynamic or neuromodulation. So sonodynamic therapy relies on a concept which is basically the activation of a non-toxic chemical substance with a sort of form of energy. It is derived basically from photodynamic therapy, where the perfect example is in melanoma. 5-LA is administered to the patient, and then with light, the interaction between light and 5-LA generate reactive oxygen species and other biological effects in order to destroy the tumor. But of course, for brain tumor, we need to go deeper, and we know that the light has the penetration of light is not much. It can go a few millimeters within. So the idea is to go deeper into the tissues using ultrasound and using a similar approach. So basically, the idea is to look for these chemical agents, which usually are dyes, that can selectively accumulate in the target region only. Then with low intensity ultrasound waves that can go deeper in tissues than high frequency, high intensity ultrasound wave, sort of have this interaction only at the target area and either activate the sensitizing agent, or also the other idea is that the sensitizing agent enhance the ultrasound wave activity. In this list, I will not go over each of these sensitizers. There is a list of all the sensitizers that have been tested in the last years. As you can see, 5-LA, it is interesting for us because 5-LA is one of the possible sensitizers. And talking about the mechanism of action and the bioeffects, there are three main, basically now there are two main mechanisms of action, which are the generation of reactive oxygen species and some sort of sonomechanical mechanism that in turn induce different bioeffects, cytotoxic effects, anti-angiogenetic mechanism, and also, let's say, upregulation of the immune response against the tumors. And so the mechanism of action for the generation of reactive oxygen species, there are two main theories. They all relies on basically the microcavitation induced by the ultrasound waves at the target region, which on one hand induce pyrolysis mechanism, on the sensitizing agent, which in the end induced the generation of reactive oxygen species. Then the other one is, which is very interesting but more difficult to demonstrate, is there is the hypothesis that this sonocavitation enhanced by the sensitizers generate photons deep in the tissues. So basically we are performing a sort of photodynamic therapy in the depth of the tissues. The light that are, or actually the movement, the oscillation that interacts with the sensitizers, which changes its state and generates reactive oxygen species, which in the end induce apoptosis and necrosis and ultimately cell death. And this is a study published last year by a Chinese group where they showed that for sure there is a generation of oxidized product when performing sonodynamic therapy using cyanoporphyrin sodium, which is one of the sensitizers used to treat the glioblastoma cells. So the ROS are for sure involved. Hyperthermia was thought to be involved. This is a study conducted 15 years ago by Professor Heinin, which is one of the pioneering focused ultrasound. And actually, of course, when we raise the power, we raise the temperature as well, and we induce a higher degree of cell death. It is also true that it's not necessary to use so much power in order to have a certain biological effect, and the risk is to generate unwanted damages in the surrounding areas. If we raise the temperature, we induce inertial cavitation. In this paper, instead, the authors showed that 5LA, so the sonodynamic therapy with 5LA was able to induce, to reduce the expression of vascular endothelial growth factor in a glioma model. So this is probably more related to the mechanical activity induced by the ultrasound rather than the generation of the reactive oxygen species. And also the modulation of the immune response, I think it's really similar to the one that we obtained with blood-brain barrier opening, because the microcavitation probably induced a sort of sterile inflammation, and really the motion induced by the ultrasound induce the tumor to expose the antibody and really affects the tumor microenvironment. So in this paper, they show that the activation of the lymphocyte, the CD8 lymphocyte, was enhanced in the sonodynamic therapy group. So going back to the sensitizers and thinking about 5LA, 5LA is a perfect sensitizer for brain tumors, especially for glioblastoma, because as we all know, it's used daily in the OR. I mean, at least in our OR. It selectively accumulates within the tumor, and it has a huge advantage over all these other sensitizers, and the advantage is that it is approved for clinical use. So if we want to translate all this research into a clinical study, we are in good shape if we think of using 5LA. So a few examples of how 5LA works in conjunction with ultrasound for sonodynamic therapy in gliomas. This is a paper conducted at the University of Virginia by Dr. Sheehan's group. They showed clearly in vitro how the sonodynamic therapy with 5LA in glioma cells induced cell death, apoptosis, and necrosis compared to control group, to the control group. And in our lab, we performed a sort of a in vitro study similar to there, but we're working with Serena Pellegato. She's a very good immuno-oncologist in our hospital, and we evaluated the immunogenicity induced by sonodynamic therapy, and we found that sonodynamic therapy with 5LA induced the glioblastoma cells, the GL261 cells, to expose the MHC1 antigen, CD86 and CD80. So really, it unmasked the tumor. In vivo, these are some few examples of sonodynamic therapy with 5LA in gliomas in vivo. This is a paper published a few years ago by Professor Umemura, who is one of the pioneers in sonodynamic therapy. And their group showed that sonodynamic therapy is really effective in this intracranial glioma model in order to reduce and shrink the tumor. And this was confirmed always in Japan by Professor Kobayashi using, instead of an external element device, they performed a similar experiment using the Incytec system, both in vitro and in vivo. And they confirmed that 5LA is a very good sensitizer for sonodynamic therapy in order to tackle malignant glioma. And this is something that we discussed before about the thermal, the thermal rise. This is always the group led by Kullervo-Heinonen, where basically they evaluated whether thermal rise was effective or was enhancing sonodynamic therapy, and they found that the thermal rise doesn't really change the outcome of the treatment. So, and this is a very good, it's very good news, because we decrease the risk related to the procedure. Of course, there are other sensitizers that can be and should be studied for brain tumors, because as we all know, 5LA is a very good sensitizer, as we saw, but is mainly limited to glioblastoma. Whereas fluorescein can be another option. The idea came because another group in our hospital, led by Dr. Fairley and Dr. Acerbi, they published this very interesting study showing that fluorescein is uptaken by different histotypes. So the idea is that probably not only glioma, but also other brain tumors can be in the future treated with this modality. And the idea actually of using fluorescein to activate fluorescein is not new, because this is a paper published in 1931, and the idea was to activate fluorescein for cancer treatment. Actually, they used X-rays, so probably it was effective because it was a radiation therapy, but the idea was there anyway. And we found this paper that showed that the mechanism is similar, and fluorescein, under certain conditions, is able to generate reactive oxygen species. So while at UVA, we decided to test this modality in a subcutaneous glioma model in rats. We used the usual the clinical dosage for fluorescein, and the parameters we used were similar to those used. We derived those parameters from the literature. So again, we used very low frequency, a low duty cycle, but a very long period of sonication. Like we performed 20-minute sonication for each animal. It's like slow cooking the food instead of using a lot of heat. And actually, the results showed that the sonodynamic therapy was really effective in reducing tumor growth, especially with when we were in the range of in the higher ranges for sonodynamic therapy. And to give you an idea, when you perform thermal ablation, as we saw in one of the first slides, we use more than 100 watts per square centimeter. Here we're talking about 6 watts per square centimeter. So it's a much less power needed. And these are the findings in terms of induction of apoptosis and necrosis. The degree of apoptosis was not very high, but probably this is due because of the fact that we sacrificed the animal at 7 days after the treatment, and probably the highest degree of apoptosis is within the first hour. So probably more experiments with more time point I think are needed in order to better understand the phenomena that occurs here. In our lab, where we are now doing some intracranial study, we're doing this, trying to replicate the study that performed the sonodynamic therapy for intracranial glioma with 5LA. We're doing this with fluorescent, and we are looking more at the tumor microenvironment, at the immune response. Again, we had the same setup with four groups, the controls plus the sonodynamic therapy group, and the system setup is really similar. The MRI performed after the treatment showed that the fluorescent group, the sonodynamic therapy group, was the one with the best response to to treatment. And evaluating the immune response, we found that the myeloid-derived suppressor cells were still highly expressed by the control group, whereas the sonodynamic therapy group had a really lower amount of MDSCC, and whereas the CD8 T cells were decreased in the control group and much active and much higher number in the sonodynamic therapy group. So probably there is really modulation induced by the sonodynamic therapy or the ultrasound alone on the tumor microenvironment that is really something that is worth exploring further. We then, in order to move sonodynamic therapy to a clinical phase, also we performed a safety study, a safety and feasibility study in a large animal model. This is an experiment conducted at UVA in using pigs. Here, the idea was really to evaluate the eventual damage induced by sonodynamic therapy on the normal brain. So there is no tumor model here, but the animals were divided into groups. One was given 5LA, one was given fluorescent. We compared the two sensitizers. The craniotomy was performed, and because the shape of the skull of the pig doesn't allow to use the Incytec system for sonication, it's a geometric issue. And then the animal was evaluated with a serial MRI, and then the animal sacrificed, then the brain extracted for a histopathological evaluation. As I mentioned, we had to perform the craniotomy, then the gap is filled with water for acoustic coupling. Then the animal lays facing the floor with the ultrasound device is facing upwards. Here you can see all the 1,000 elements. We use only the central portion in order to go through the craniotomy. This is the a screenshot of the control system, where we perform. You can perform the planning of the treatment, and we chose to sonicate to different regions: the frontal white matter and the thalamus, because as you know, the vascularization is different, the cell populations are different, so it was worth it to explore different areas, and we performed sonication, which were roughly the size of 1.50 millimeter cubic, a cube of 50 millimeter per side. Then the animal were scanned with the MRR at the end of the procedure, day 1 and day 7, and we didn't found any sign of hemorrhage or damage, nor we found it macroscopically after having extracted brain or on histopathology. So the idea is that this procedure is totally safe in the presence of low dose of sensitizers. Then moving to the clinical phase, there are actually 2 clinical trials ongoing for studying sonodynamic therapy with 5LA. The first one is being conducted at the Barrow Neurological Institute in Phoenix by Dr. Senais. It's a phase 0 study. Where they're performing sonodynamic therapy using the MRG-FUS system in combination with an intravenous formulation of 5LA. So the trial is ongoing, and apparently I heard the results are very good, and they are trying also to establish what the best parameters are. So they're escalating the dose. Whereas there is another study that has been approved in my institute. So we hope to start enrolling patients very soon, since this has been approved by the Ministry of Health, Italian Ministry of Health. It's a safety and feasibility study, but we're thinking of sonicating and treat de novo glioblastoma. So the Phoenix study is on recurrent glioblastoma. Our study is on de novo glioblastoma. So the idea is to perform sonodynamic therapy prior to surgery. So the patient will be treated with sonodynamic therapy. Then we will perform seriated MR 2-3, and then 2-3 weeks after the treatment, the patient will undergo surgery, and then we will resect the tumor and evaluate the outcome of the treatment. So actually, in conclusion, I hope I provided you with an overview of how sonodynamic therapy works and what are the possibilities offered by this treatment. I think the preclinical studies have showed that it's safe and feasible and also effective. There are, of course, many questions that needs to be addressed. So, for example, developing new sensitizers, or better understand how the current one works. Also, maybe we can exploit the endogenous fluorescence. Parameters also are still debated. So, for example, we will use in our trial low frequency, low power, and longer sonication, whereas in Phoenix, they are having a different approach, and they are looking only at the energy they deliver. Considering that the ultrasound are not harmful per se, differently from radiation therapy, we should consider also the options to perform multiple treatments if this proved to be effective. There are also many other modalities with which sonodynamic therapy can be combined. For example, with microbubble, we can probably enhance even more its effect, and there are piezoelectric microspheres targeted sensitizers. So there are really many exciting options. And also the device that we use for treatment should be, I think, discussed, because MR-GFAS is, I think it's a great tool for ablation. It's great for this early stage because we have a quasi real-time feedback. It's perfect for planning, but I don't think we need to be so precise when addressing a big lesion, because it takes time. Sometimes it's not possible to cover the whole volume. So it's quite cumbersome. Probably other devices such as navigated system or implantable devices where we can be less precise because we're not causing damage with the ultrasound per se is envisaged. So with that, I'm done, and thank you for your attention, and I'm happy to take questions.
Awesome. Thank you so much, Francisco. That was a great amount of work, and I congratulate you for the effort you've done in multiple countries to kind of push this field forward, and also for your late night attention.
Thank you.
A couple questions I had just for people who are kind of using this as a tutorial. If you could just go over again just exactly what the selectivity is of sonodynamic therapy on tumor cells, and why is it targeting the tumor cells and not the surrounding tissue, and what is the depth that you're able to reach with this, even with the cranial window that you're using?
The selectivity is mainly is provided by two elements. The first one is as I mentioned, is the sensitizer, which to be a sensitizer, it has to selectively accumulate in the area. So you mentioned the sensitizer to be uptaken by the cells. Actually, yeah, this is true for 5LA. Fluorescent has a different mechanism. It extravasates, but still it remains in the tumor volume. So this is mainly in the tumor volume. So this is the most important thing. And then the other selectivity is offered by ultrasound if we use focused ultrasound, because focused ultrasound can be tightly directed only in a certain area only. And as I said, the single beam doesn't, yeah, of course it will provide some biological effect, but the final effect is only at the point of conversion. So you have two safety systems. One is offered by the sensitizer, by the other one by the fact that you can focalize the ultrasound beams only in the area that you want to treat.
Yeah, no, it'd be interesting to see the difference between the two trials, just because it's the cells in the periphery that we're worried about, right? It's the cells that escape the tumor resection. So maybe the preoperative treatment will allow you to outline that tumor a little bit better and do the treatment, just like we're finding now with radiosurgery, right? For mets, like it's some data showing that preoperative radiosurgery might be better than postoperative because you could outline it better. Is that what you're kind of hoping in the trial that you're doing there in Italy?
Well, actually, one of the reasons because we are treating the tumor before the surgery is that one of our hope is try to better understand what happens in the tumor bed after this treatment. And the other one is that performing 2-3 MR before surgery, between the sonodynamic therapy and the surgery, we can eventually observe a sort of a shrinkage of the tumor. Of course, this is a safety and feasibility. The MR monitoring is to assess that there are no damage is induced by this treatment. But eventually, we might observe a sort of a volume reduction or MR changes in the tumor even immediately after the sonodynamic therapy. Of course, I agree with you that in glioblastoma, especially in glioblastoma, we need to treat also the area around the tumor. Yeah, the problem in that case is that maybe we will not have enough sensitizer in those regions, except for the I don't know, periventricular zone. But then we will have some functional tissue in that area, so it's kind of tricky. But
yeah. And then just a question on the depth too. I mean, a lot of the data when we were looking at photodynamic therapy worked so well in the mice and the rats because the brains are so small when you're doing treatment, 6 or 7 millimeters of depth for photodynamic therapy was great. But then when you started moving to the pig and to the human, it was, you found quickly that the penetration is not that good. So with the window of the craniotomy that you're making, are you able to reach all the way down to the bottom of the thalamus and like deep areas like that with this technique?
Yeah. I mean, with the imaging, I showed we were reaching easily the midline. So yeah, the attenuation is 10% as we measured. So it's 10 times less than the skull. So yeah, we can go deep, and also with navigated system or with because with this, especially with this modality, we're using low frequency ultrasound, and low frequency ultrasound, they trespass the skull or the wing or the prosthesis much easily than high frequency. So,
and I'm sure you're probably not worried about the bouncing of the bone from the contralateral side with some of the high frequency ultrasound, right, from the skull base.
Yeah, that's a very good point. Yeah, of course there is some reverberation. Yeah, that's for sure. Yeah. Well, actually, the power that we are using here is much less than the power that we are using with the CUSA. So, and there is a lot of reverb. I try to visualize the beam generated by the CUSA with the ultrasound. So really the monitor goes white.
Got it.
So it's much less energy. So.
Got it. Well, let me open it up to the panelists because I think they have a couple questions prepared. Who wants to go first?
I can go.
Yeah.
Thank you so much, Ed. That was an amazing talk and something I'm very unfamiliar with myself. I'd heard about it, read papers on it, but haven't really seen it in action. I just had two questions. The first one is just more of a basic question. In terms of patients, when you apply this sort of focused ultrasound, is there any issues in terms of the skin surface, any sort of complications there, or along the tract of the therapy delivery trajectory of? Are we noticing anything on MRIs or anything clinically with patients?
Yeah, well, this is an important thing, especially when you think about high intensity focused ultrasound rather than low frequency. But yeah, the scar tissues, the scar should be usually is avoided. Also because the transmission of the ultrasound is different, but yeah, that should be definitely avoided, and also calcifications, and well, of course, sinuses, frontal sinus, or everything. The air along the beam should be avoided. And also, it has to be said that especially when using the Insight system, the patient has to be totally shaved, because you don't want if there are air bubbles trapped in the hair, they might start cavitating, and then you can generate skin lesions.
My second question was something we were talking about this week regarding ALA itself, and some institutions are starting to use ALA for the trial basis for meningiomas. And outside of gliomas, is there a role for sonosensitizers for other types of brain tumors? And therefore use of focus ultrasound in the context of other tumors, let's say meningioma or anything else?
Well, brain mets, first of all. So, for example, I think there is a trial on melanoma brain mets with 5LA. And then, yeah, possibly meningiomas or chordomas. It's an option. I mean, as a surgeon, I wouldn't really want that, but
Of course, no, totally. And I agree. I think we all agree with that one.
But of course, if we can go non-invasive, I mean, it would be better, of course. But for sure, I think the next in line after the glioblastoma are the brain mets. And then we'll see the rest.
Thank you.
Also cavernomas, I think. So deep-seated cavernomas might be a good option to burn them with sonodynamic therapy, like pontine cavernomas or stuff like that.
Thanks. That was a great talk. And just to kind of piggyback on the line of questioning from Nitesh, I know there are some groups interested in focus ultrasound for low-grade gliomas like DIPGs in Columbia, Toronto. And given that they don't really take up 5LA and fluorescein, like what's your take in application of sonodynamic therapy in the kind of way you described to be able to try to apply it to low-grade gliomas?
Well, yeah, that's a difficult question. So I'm not sure that we can rely on the uptake of the sensitizer by the tumor, but rather the other option is to open the BBB and let the sensitizer get out in the area of the tumor. So this sounds much more complicated, but this is something that is been performed not for sonodynamic therapy, but it's Graham Woodworth in University of Maryland is doing a study in order to perform to better understand BBB opening. So in low-grade glioma, they are opening the BBB, then they provide fluorescent, then they resect the tumor, and they see if the dye extravasated in the area where the BBB was open. In that case, you can eventually perform sonodynamic therapy. For sure, I think that for the IPGs, for example, it's probably much easier to perform blood-brain barrier opening and find a good drug to tackle this kind of lesion.
Thanks.
That was a great talk. Very, very interesting subject. Do you feel that the SDT will be used more as a preoperative to sort of help with tumor resection or to get rid of more tumor, or is it going to be used more of a salvage therapy?
I mean, if it works for glioma, for example, it can be used preoperatively and even maybe as the only option. I mean, I'm not that positive, but eventually as a first-line treatment. Also, of course, it can be used at the time of recurrence. We'll see how the Phoenix study goes. For sure, it can be a perfect option for recurrent gliomas.
Alexis.
My turn. Very interesting presentation, Dr. Prada. I only have one question, and that is if you have seen any synergistic effects between radiation therapy or any other adjuvant therapies and sonodynamic treatments.
No, I don't have experience with I mean, it's already complicated like this. So I think we're really early stage and trying to combine this, it's really complicated. There are some study coming out. There is you mentioned the combination of ultrasound with the radiation therapy. There are studies undergoing ongoing that are aiming at evaluating whether hyperthermia induced by focused ultrasound can enhance the radiotherapy, but not involving sonodynamic therapy. But yeah, I think, as I mentioned in the last slide, there are lots of avenues that should be explored. I think we are really early stage. So despite being already into 2 clinical trials, there are many questions that need to be asked, to be answered.
Thank you.
And for the trial, how long are the treatment times that you're planning for the trial for each one of these patients? Obviously, it depends on the volume of tumor, I'm sure, but are they? What is the kind of what are you expecting for the patients to undergo time underneath the ultrasound?
So you mean how long will each
session? How long each session is?
I think it will be like between 2 and 3 hours.
Okay.
So basically, with the Insightec system, we will be using the current software for BBB opening. We are performing BBB opening, and each treatment lasts between 2 and 3 hours.
And in your institution, I'm sure this is going to be a touchy question. Which physicians are going to be involved in the planning and execution of focused ultrasound?
Well, it's a teamwork. We have of course, you have a physicist that needs to tune the machine before starting. Then there is a team composed by the oncologist, the radiologist, and neurosurgeons. Also because you need to place the stereotactic frame, and the anesthesiologist, of course, because these long procedures, you need to keep the patient comfortable, painless. So really, there are many people involved.
But you see neurosurgeons as taking a major role in kind of the planning and being there for these procedures, or do you think that this is something that's going to eventually kind of end up being not something that's neurosurgery involvement?
Well, actually, it's not really a surgical procedure, but I feel that either you have a very good relationship with the radiologist, but in an ultimate analysis, I mean, if we are going to perform the surgery or you perform the surgery, you know the situation better than anyone else. I mean, there is no MR that can tell you what you saw in the OR. So I think for sure the neurosurgeon should be always involved.
And one last question. For postoperatively, how long are they waiting? I mean, obviously you have to wait for the air to resolve and probably the blood products to resolve and for the cavity to be clean before you would take the patient for low frequency ultrasound, or is that not the case?
No. Yeah, that's a very good point. Yeah. Of course, you need the air to be clean, and I mean the air. You can avoid the air with proper planning, but since you can induce cavitation if you have air in the area, I would wait for even with low power ultrasound.
Got it. Okay, great. Any other questions from the group? Okay, awesome. I think it's almost midnight there, so we'll let you go. But
yeah,
really exciting stuff. Really appreciate it. Looking forward to hopefully working together in the future with future clinical trials. And congratulations again. Thank you.
Thank you.
Thank you very much for the invitation again. Bye.
Take care.
Take care. Bye-bye.